Anna Forendon, manager of ICAN, and I really am so pleased to be here. I'd like to welcome all of you, and just want to apologize for the glitch. Susan, if we can just help that the interpreters are not audible to the rest of us, you know, while we are talking. Let's double check for us on that. We've got one or two slight changes on the agenda, but I will discuss it as we go along. Just while we're waiting for everybody to join, I just would like to do some housekeeping rules. If everybody can keep their mics muted and their videos off, we will ask the speakers to just open up their video when they being introduced, and then they can switch it off if they want to while they're busy presenting. At the end of the two presentations, we will have a short health break just to give the speakers a chance to rest their voices, and then we will carry on with the Q&A. So for all the people participating, if you have any questions, please look at the Q&A box at the bottom of your screen, which says Q&A. Post your questions there, and during the course of the morning or the afternoon, we will answer that or do that live as soon as we're done. You will also see at the bottom of your screen on the right-hand side, there's interpretation box that you can click if you want to have interpretation in Arabic or in Portuguese. Otherwise, it will be in English. I also want to just remind you of our French session that will be running tomorrow. So all our French speakers, the same session will be running tomorrow. So thank you very much to everybody. I would like to hand over now to Bethlehem from Africa CDC. She's going to do the EP update for us on the status of COVID in Africa. Over to you, Bethy. Thank you.
Thank you very much. Good afternoon, colleagues. I will give you a quick update on the COVID-19 epidemiological situation in Africa. Sorry, this is to confirm. Can you see my screen?
Yes, we can see your screen. We can see, you can carry on. See your screen, you can carry on, Betty.
Okay. Starting with the global situation, to the left of the slide, there is an epi curve showing the number of new COVID-19 cases reported globally by the 6 WHO regions. The number of new COVID-19 cases reported globally has decreased in the past 4 weeks. And last week, over 11 million new cases were reported globally, which is a 9% increase in the number of new cases reported while compared with the previous week. As of yesterday, over 458 million new cases and 6 million deaths have been reported globally, with case fatality rate of 1.3%. Looking at the continental situation, the map on the left shows the cumulative cases being reported from each member state. The majority of member states are reporting between 1 to 100,000 cases, as shown in the light pink color. 3 member states, which are Tunisia, South Africa, and Morocco, indicated in the dark red color, have now reported over 1 million confirmed cases of COVID-19. The chart on the right is showing the number of new COVID-19 cases reported by epidemiological week, and this continues to trend downward for the last 9 weeks, as shown by the 7-day moving average. We also observed a spike on the new cases in the past few days because of a batch report we received from Tunisia. In the last epidemiological week, there was a 14% increase in the new cases reported compared with the previous week. As of yesterday, 6 p.m., more than 11.3 million cases have been reported, with more than 250,000 deaths, resulting in case fatality rate of 2.2%. Of the cases reported, 93% have recovered. Taking a look at the trends over the past month for the continent, this chart is showing the number of new COVID-19 cases reported by week for the past 4 weeks. And over the past 4 weeks, on average, the number of new COVID-19 cases have been decreasing by 15% each week. This slide shows the new COVID-19 cases over the past month for the 5 AU regions. Each region on this chart is showing the number of cases reported over the past 4 weeks. And the red and the black lines represents the percentage change of the new cases. By region, over the past 4 weeks, there has been an average of 17% decrease in the central region, 16% decrease in the eastern region, 14% decrease in the northern region, 12% decrease in the southern region, and 12% decrease in the western region. The map on this slide shows the distribution of the new COVID-19 cases reported per 1 million population per day across the continent. In the past EP week, 40 countries reported less than 5 new cases per million population per day, while 3 countries, and these are Mauritius, Seychelles, and Tunisia, reported 80 or more new cases per million population per day. This week, we do not have information for 5 countries. We also observed that there is a slight increase in incidence for 13 member states compared with the previous week. This slide is showing the AU member states that have reported the Omicron variant. Since last week, 1 member state, that is Chad, has reported the presence of the Omicron variant, and cumulatively, 44 member states have reported the presence of this variant. This chart is showing the number of new COVID-19 deaths reported by week for the past 4 weeks. The red line shows the trend in the percentage change of the new COVID-19 deaths reported in Africa. Over the past 4 weeks, there has been an average of 30% decrease in the number of deaths reported across the continent. The chart on each panel on this slide shows the number of new COVID-19 deaths reported over the past 4 weeks. By region, over the past 4 weeks, there has been there has been an average of 26% decrease in the central region, 27% decrease in the eastern region, 30% decrease in the northern region, 23% decrease in the southern region, and 5% decrease in the western region. The map on this slide shows the COVID-19 case fatality rate by AU member states, classified into 4 categories. 33 member states are reporting a CFR that is higher than the global CFR of 1.3%. 11 countries have a CFR that is less than 1%, and 2 member states have a case fatality rate that is greater than 5%, and these are Somalia and Sudan. We also observed a slight decrease in CFR compared with last week in 1 member state, that is Botswana. This slide is showing the summary of COVID-19 testing on the continent. Cumulatively, over 103 million tests have been conducted, with the test per case ratio of 9 and a positivity rate of 11.1% respectively. In the past week, more than 600,000 new tests were conducted, which was a 20% decrease in the number of new tests conducted in week 10. Looking at the test positivity by AU member states for the past epidemiological week, 32 member states have a test positivity that is less than 3%, while 3 countries, these are Egypt, Libya, and Tunisia, have a test positivity that is 12 and above. We observe a slight increase in test positivity for 14 member states compared with the previous week. We do not have a laboratory information for 15 member states this week, and test positivity has increased across the continent. And in the past epidemiological week, there was a 37% increase in positivity while compared with the previous week. This is all from my side. Thank you. Over to you.
Thank you very much. Really insightful to see and hear what is happening. I would also like to just welcome all our panelists, and I see that ICAN Chair Prof. Shadai Ogunsala is also here with us, so welcome to everybody. The next speaker I would like to introduce is Luca Fontana. He's the Technical Officer at the Health and Technical Logistics World Health Organization. He's an environmental toxologist, epidemiologist working on health logistics, wash and infection prevention control in WHO, and since 2013 he's been working in the major outbreak preparedness and responses in Africa countries. His main expertise is the design and management of infectious disease treatment centers. He led and contributed to several WHO works on environment and engineering control measures relating to infectious diseases, including the design and indoor ventilation as a risk reduction measure. One of his main areas of work is the strengthening of a multidisciplinary and holistic approach to the infectious diseases emergency preparedness and response. Welcome, Luca, and over to you.
Many thanks, Anna, and I would like to thank ICAN and African CDC for this great opportunity. I'm going to share my screen and stop my video. One second, this is not the right one. Okay, now you should see properly.
Yes.
Perfect, thanks. So as you already heard, by background, I'm a medical background as a toxicologist, epidemiologist, but I mainly work with the architect and the engineer. And within the last couple of years, our work has been focused on indoor ventilation in healthcare setting and beyond as well, focus on infection prevention and control. And today I would like to look with you the mechanism of airborne transmission and how ventilation can mitigate the risk of infection. In a very simple way, we were used to talk about short range and long range airborne transmission, which in reality is a continuum. We emit respiratory particle whenever we breathe, we speak, we sing, and those aerosolized particles are water-based solution of salt, mucus, protein, and may contain other material that is present on the surface of the respiratory tract, including pathogen. Those viruses on the surface of the respiratory tract can be exhaled within those emitted particles. And now, how ventilation can help to reduce the risk. But first, let's see what happens in an indoor space where whenever we have one infector, so one person emitting a respiratory particle containing viruses and a susceptible host. In this hypothetical space, there is no ventilation. Our susceptible host is 2-3 meters afar from the infector, which means that there is no risk of direct inhalation or deposition of particle. And after a period of time, what we see is the concentration of this respiratory particle that the small one, can remain suspended in the air for long period and travel far beyond the 1 meter or 2 meter distance, we can see that the concentration of this potentially infected aerosol increase in the space. As of today, we don't know what's the threshold, what's the accumulated dose that can trigger the infection or not. But what we know is that as the concentration increase as well the risk of infection. So what's the role of ventilation in this? That thanks to the ventilation, we can control the concentration of this infectious aerosol in the indoor space by removing or diluting this respiratory particle and keep the concentration at low. We know that we can reduce the risk of infection. Now, talking about ventilation, we know that we're talking about 3 basic elements. So the ventilation rate, which means the amount, the volume of outdoor fresh or clean air that is provided into the space, and so replace old air with the new air to dilute the potential pathogen in air. The airflow direction, so the direction in the space, which we know it should always be from the clean zone to the less clean zone. And the air distribution or airflow pattern. Why? Because the concentration of the emitted respiratory particle is not homogeneous in the space. So we should make sure with our ventilation to replace all the old air in the space with new air. It's any space. So not only in the central part, not only in the corner, but the whole volume of our air. Now, talking about healthcare setting, we know we have a specific standard for natural ventilated building and mechanical ventilated building, and as well a division in between area where AGP, aerosol generating procedure, are performed, and other standard for where AGP are not performed. Why this difference in between natural and mechanical ventilation? Because with the mechanical ventilation, we can ensure a constant ventilation rate, while for the natural ventilation, the requirements are a bit higher and are expressed as an average, because it's more difficult and challenged to control across the day and across the year the natural ventilated building because of seasonal change, wind change, the wind directional change, and so on. Those value apply to isolation room, and not only for COVID, but I guess many of you are familiar with the standard due to tuberculosis. So where we have 6 or 12 air change per hour for mechanical ventilated building, and 60 or 160 liter per second per patient for natural ventilated building. You see as well the units are a bit different. So with mechanical ventilation, we refer to air change per hour. So how many times within an hour we replace the whole volume of our space, while for natural ventilation, we talk about liter per second per patient. So a unit more linked to the occupancy rather than the space itself. However, knowing how many people we have in our space and the size of our room, we can easily move from liter per second per patient to air change per hour. Now, we've been discussing about basic mechanism of airborne transmission and the standard, but how can we improve the indoor ventilation of our health facility? Early in 2021, in collaboration with a group of expert architect, engineer, urban designer, and IPC specialist, we published a document called the Ventilation Roadmap to improve and ensure good indoor ventilation in the context of COVID-19. This document is available online, and it covers 3 specific settings. So healthcare setting, non-residential setting such as school, university, office, market, and then residential setting, household facility. But today we're here to talk specifically about healthcare setting. So this document, the Ventilation Roadmap, beside the 3 specific settings, is divided into mechanical and natural ventilation. So if you look at the healthcare setting specifically, you will find 2 different chapters. One with recommendation to improve ventilation with HVAC, so with mechanical ventilation system, and a section dedicated to naturally ventilated building. The structure, it's quite simple and straightforward and enable user to assess the ventilation, the indoor ventilation, their specific building, step by step, recalling the standard and proposing some improvement strategy. Some of them are mutually exclusive, so either it's one or the other, while other strategy can be implemented simultaneously. Let's look at the first one together. The first question and the first step is the ventilation rate. So the volume of air that is brought from outdoor to indoor. As we're talking about naturally ventilated building, we know it's either 160 liters per second or 60 liters per second per patient. Once we assess our ventilation rate, and this can be done or with a simple mathematical formula that you can find in the document, it's just an estimation, but it helps to have an idea, or can be done by expert, engineer or architect that have the know-how to estimate the natural ventilation by knowing the position of your building, where it's located, the wind direction across the year, and the climate condition. Once we know our ventilation rate, what can we do to increase it if needed? But as we're talking about natural ventilated building, the first option is to assess the opening, location, and surface. So where are our windows? What's their surface and location into the space? And if possible and needed, either make the windows bigger, leave it open, or leave the door open as well. Another important advantage of natural ventilation is that we can enable cross ventilation, which means, as you can see in the small drawing here, enable the air to come in from one side and move out from the other side, because this increases significantly the ventilation rate, so the amount of air that we bring inside. Here, however, I would like to flag something important that I already mentioned, the importance to control the airflow direction. So what we need, in this case, we really have to pay attention that our airflow is moving from the clean area to the dirty area and not the other way around. So we don't want the air from the patient's room to move into the corridor, but we want this to move outside, maybe out from the window. How can we check it? There are different methods with different level of technical complexity. A very simple one, a smoke test with incensus or burning something that can produce smoke and see the direction of our indoor ventilation. If this is not enough, so we can consider the option to integrate our natural ventilation system with some air cleaning device. Being in a air setting, the filter should be EPA filter. We should pay attention to the device clean air delivery rate, to not oversize or undersize our air cleaning device. Pay attention to where we're going to install this air cleaning device. And another important consideration I like to flag is that those devices, though they can help, they do not replace ventilation in any circumstance. What does it mean? That if we have a room without any windows, without any mechanical ventilation, we cannot just install an air cleaning device and think that this will solve our problem, because it's not enough. And moreover, before considering the purchase and installation of one of those devices, please consider not only the initial cost, the initial investment for the purchase, but as well the maintenance, the spare part. Filter must be clean and replaced according to the manufacturer recommendation, which is a cost, as well as the possibility to find skills people in your country able to ensure maintenance to the specific supply device. We talk about airflow, so the direction where our air is moving from where to where. What can we do to, once we assess our airflow and we see that there are problem, so the airflow is not moving in the direction it should be. So either we can move and change the setup of our clinic. So changing the patient's room, turning the patient's room into an office and the office into the patient's room, if this helps and make sure that our airflow is moving in the right direction. Installing a wall or window air extractor or wild birds. So installing a fan to facilitate the control of the airflow direction. It doesn't have to be something electrical, can be something that is functioning by different pressure or buoyancy, or and like we see in many different settings. Or, okay, the use of pedestal fan close to the window to help. However, this is probably not the best solution for healthcare setting. Or building work, so building a chimney to enable the stack effect of the natural ventilation. An option for the area where IGP are performed can be to add an anteroom in order to enable a better control of the airflow direction. A double door in anteroom could facilitate the control of this airflow and prevent the air from the patient's room to move into the patient's in the staff corridor, for instance. It doesn't have to be concrete building or construction, can be something temporary. I saw many hospitals using a plastic door to create this temporary anteroom solution, which enable as well visibility on the patient's area. Another important topic is the management of exhausted air. So we don't want our potentially contaminated air to move, for instance, in a staff area or outdoor where people, family, visitor, or animal can walk nearby. So that's why it's important to control where our exhausted air is pushed outdoor. If it's outdoor on the roof, It's just a matter of ensure that it's more than 2 meter high. And if it's horizontal, just make sure maybe to fence this exhausting area and ensure a 4 meter distance, just to avoid people and animal to receive this potentially contaminated air. An important question is heating and air conditioning. I understand in many warm countries recommending to avoid the use of air conditioning can be a problem. They are not recommended, especially this one you see in the picture, because this specific coil unit, they recirculate air. So they just take the air from the patient's room, they cool it down and they recirculate. So there is no air change. But this means that the concentration is keep the concentration of potential infectious aerosol in the room is not affected. So the first recommendation would be to avoid it. However, as I already mentioned, we completely understand that this is not always possible. And that's why whenever air conditioning with air recirculation are used, it's extremely important to ensure that the ventilation rate requirement are met, which means that on one side, we ensure that the dilution of our potential aerosol is maximized. And with air conditioning, we can ensure patients and staff comfort. But please keep this in mind. So keep in mind the importance of the ventilation rate and airflow as well whenever you use air conditioning that are not ducted, so that they recirculated air. Again, and the airflow. You know, this device blow out fresh air, and it's important to pay attention on how this airflow affect the general airflow within the space. Two other important consideration whenever we talk about ventilation in African setting, or whenever we have vector-borne disease that might be endemic in some area, is the use of mosquito nets. So please keep in mind that the use of mosquito nets reduce significantly, we can say up to 50%, the natural ventilation rate. So an open window with mosquito nets and reduce our natural ventilation rate significantly. And this is important to keep in mind. Another important consideration is outdoor air pollution. One of the problems with ventilation is that it's very challenging to issue general recommendation because everything is on a case by case. So the wind direction, the temperature, and as well the outdoor air pollution. We understand that opening a window nearby a manufacturer that is constantly emitting chemical pollutant can be a problem. And that's why it's important to keep this in mind before announcing our natural or mechanical ventilation as well, in case we don't filter the air. But something important to keep in mind is as well that several studies of human exposure to air pollutant indicate that indoor level may be 2 to 5 times higher indoor than outdoor. What does it mean? That most of the time, the air pollution inside our space, it's much higher than outdoor. Again, this should be assessed on a case by case, but I thought it was important to share with you. and what to do in case the air pollution, outdoor air pollution in our area is particularly concerning. But in that specific case, air filtration may be more appropriate that increased ventilation rate by naturally means. However, please, before looking into air filtration, please consider all the possible solutions. A long-term approach I would like to share with you. So far, we have been talking about recommendation to improve existing building, but maybe it will be useful to invest on the COVID-19 emergency with a long-term approach. And I would like to share with you a project, a few information on a project we have been carrying out with a couple of universities from Italy and Burkina Faso, where together we study the structural design for a TB health center, leveraging the structural design to enhance and improve natural ventilation. So a structural design that enable cross ventilation with large opening oriented outdoor, making sure that the cross ventilation is not pushing the contaminated air into the staff area, ensuring as well ventilation in the toilet to avoid stagnant push of air, and as well the use of anteroom and corridor to control the area. And why I'm sharing with you, because I think that it's important for many countries to leverage on existing investment on the COVID-19 with a long-term perspective. We know that COVID-19 is not the only respiratory infection we have to deal with on a regular basis. So why not to invest on building modification, rehabilitation with a long-term perspective, and considering the natural ventilation to reduce the cost, the maintenance, and ensure environmental sustainability as well. With this one, I would like to thanks and give the floor back to Anna. Thank you.
Thank you very much, Luca. It was really very nice and information for us. And you'll see there's quite a lot of questions. But before we move over, we do have enough time. I just want to reiterate to all our participants that there is a way that you can attend all the seminars. This is the end of series 11, but we will do a series 12 as well after 1 week break. There is a French session every week on a Thursday as well. If you do have any questions, you can either contact ICAN or Africa CDC. We will post all the presentations and all the material on the ICAN website at the end of each of the series. I'm going to now play a short video just to give the interpreters a time to just get their voices to rest before we move over to all the questions and answers from Luca and the rest of the panel. I'm just going to quickly share my screen with you. Can you see my screen?
Now, yes.
Okay. I'm just going to slideshow.
Coronavirus, COVID-19, spreads through the air. You can catch it if someone with the virus coughs or breathes on you. The virus can build up in badly ventilated areas. This increases the risk of infection. Good ventilation is one of the best ways to fight COVID-19 in the workplace. It reduces the amount of virus in the air. Good ventilation can be Natural, letting fresh air in at windows and doors. Mechanical, using fans or ducts to bring fresh air inside. Or it can be both. Ask yourself, which occupied spaces could be poorly ventilated? Walk around your premises. Look for areas that smell bad or stuffy, or that don't have mechanical or natural ventilation. Also, look for areas that are busy, especially when it's for a long time, or small or cramped areas. CO2 monitors can help you assess if a space is well ventilated or badly ventilated. But monitors can only help you decide if there's a problem with ventilation in part of your workplace. They can't help you fix the problem, but it can tell you if your ventilation is working properly. Remember, ventilation doesn't mean you can forget about other COVID-19 controls. You can improve natural ventilation by opening windows and opening doors. You can improve mechanical ventilation by understanding how your systems work and by making sure they're working properly. Don't rely on recirculation units. They don't bring in fresh air. They just move air and COVID-19 around and will prevent you identifying poor ventilation. If you have no mechanical or natural ventilation and no way of fixing this, use air cleaning or filtration units, but keep windows and doors open as much as possible. Don't forget any vehicles your workers use. Driving or parked, ventilators on and windows open. Between trips, open doors to clear the air.
The risk of COVID-19 spreading in crowded indoor spaces is much higher than outdoors. This is because COVID-19 is airborne. A fine aerosol spray from an infected person can stay in the air and spread to others. Improving indoor airflow can reduce the risk of COVID-19 transmission in your home or workplace. There are simple things you can do to improve ventilation and make your space more COVID safe. Some of the best methods are easy and low cost. You can improve natural ventilation by opening windows and leaving doors open in hallways and corridors. Do it whenever you can. If possible, reduce or limit the number of people indoors. Use electric fans or ceiling fans on the lower setting to increase airflow. You can also reduce the risk of COVID-19 transmission using mechanical methods. Heating, ventilation and air conditioning, or HVAC systems, increase airflow by bringing fresh air in from outside. They also filter air quality. You can improve this type of mechanical ventilation by cleaning your air grills and vents regularly, changing the settings on your system to increase the amount of outdoor air being brought inside, and installing or replacing your system's filter with one that has a higher grade. Portable air cleaner units can also help to improve air quality by reducing the number of viral particles in the air. If you need more tailored advice, occupational physicians and ventilation specialists can help find the right mechanical ventilation solution for you. You can find more information on how to improve ventilation and stay safe on coronavirus.vic.gov.au.
Okay, I'm going to hand over to Lizzie Sitole from ICAN to take us through the question and answers. Dr. Yewande Alimi from Africa CDC put in her apologies. I see Dr. Ario is also here, so between the two of them, they will take over the questions and answers and put it forward to Luca or to the rest of the panel. Over to you, Lizzie.
Thank you, Anna, and good afternoon, good morning to everyone, good evening, and welcome to our question and answer segment. Before I direct any questions to the panelists and to the presenters, I'd like those that have questions to kindly put them in the Q&A box, as we are not able to attend to raised hands. And I'd like to welcome the panelists and the presenters in the Q&A session. For our first question, which is directed to Dr. Luca. It reads, in a practical situation, how would you deal with issues related to ventilation in a dilapidated infrastructure in healthcare setting, and take into account the scarce resources that is in the low middle income settings? Over to you, Dr. Luca.
Thanks a lot. If we look at the different type of activity carried out in a given space, this definitely something we need to consider. For instance, if we do perform some IGP or not, or nebulization therapy, as well as I saw in another question, that's definitely oblige us to increase our ventilation rate up to 12 air change per hour or 160. Now, matter of resource, I understand the constraint of resource, and that's why I did my presentation on the natural ventilation system. I think that, and it's what we know is that mechanical ventilation is not better than natural ventilation, and natural ventilation require an investment to modify the structure, but then there is no maintenance. So that's why I'm always recommending to first look at natural ventilation to overcome the problem of limited resource. And sometimes we don't even have to undergo building modification. It's just opening window, opening door, or maybe install a small fan on the window or on the wall. So I understand the resource constraint, but first assessing what's the current situation, and then according to local resource and technical resource availability, explore what can be done, starting with the natural ventilation approach. So that's what I will definitely recommend in a limited resource setting. Hope it helps.
Thank you, Dr. Luca, for that detailed explanation. As you take a breather, I would like to direct the next question to Prof. Ogunsula. Kindly advise of air conditioners. Are they acceptable in the operating rooms? Over to you, Prof.
Thank you very much. I actually read that question as I was going through. They are not acceptable, although they're very widely used in many of our hospitals. There is a sort of general assumption that the air conditioner is also helping to dilute, is giving us fresh air and all that and filtering out. It doesn't. It just recirculates whatever you have in the theater and compounds and concentrates any infectious material. So it is not acceptable. The operating theater requires ventilation that helps to dilute all the organisms that come off the body scales as we're moving around within that theater, and requires that the air comes in a certain way that protects the patient on the operating theater. So coming from the top and going out through the bottom or from the side, and creates a safe environment at that point of care, which is the operating theater. So in a nutshell, no, it is not. And most of our operating theaters are not purpose-built or built with infection control in mind. Invariably, they're just thinking of reducing the humidity and the temperature in those spaces. So as we get better with IPC, hopefully we will be, there'll be more consultation as we have more IPC really being taken care of within the continent. So in a nutshell, no. air conditioners are not ideal for the operating theatre. Thank you.
Thank you, Prof, for that detailed response. My next question is directed to Dr. Luca. Says, what is the difference between negative air ventilation and positive air ventilation, which is recommended for COVID-19 ICU and the OR setup? Over to you, Dr. Luca.
Thanks a lot, and thanks a lot for this question, because it gives me the opportunity to link back to Prof. Ogunsola's previous answer. What's the difference? Positive and negative pressure is actually depends on who we are trying to protect. Sorry for this oversimplification, but I think it's helped to give you a better understanding and a better idea. So if you look at the COVID patient's room, the ventilation, as I said before, is moving from the staff area to the patient's area, because we don't want the infectious aerosol present in the patient's room to move out in the staff area, right? So this is, how can we achieve it? But if we create a negative pressure room, negative, it means that the air from outside move into the patient's room. Now, let's look at an operation theater. Who we should protect, who is the most exposed, is our patients. So in the case of an operation theater, what we want to protect is the patients itself. So we want to make sure that dirty air is not moving from outside into the operation room. So in that case, we create a positive pressure. So the positive pressure is inside the operating theater. So the pressure, the air pressure inside is slightly higher than outside, which means that the airflow, so the air, it's flowing from the operation theater to outdoor. And that's to protect the patients itself. And that's, I mean, operation theater or immunocompromised ward for immunocompromised patients as well. We do use positive pressure, while for isolation room for infectious disease patients, we usually use negative pressure. And that's has been a big challenge for many settings, because it's extremely difficult to change from a room from positive to negative and vice versa. But both of them are useful, and it's important to understand who we want to protect before implementing negative or negative room. Hope it's clear. Thank you.
Thank you so much, Dr. Luca, for that. And our next question is, what distinguishes between single, adjacent, and cross ventilation, especially in healthcare setting? Which one should be considered? Over to you, Dr. Luca.
Thank you. In a very simple way, imagine one room, okay? In one room, you have only one door that gives on a garden side. You leave the door open, so the air move into the space from the door and move outside from the same door. This is a single side ventilation example. What happens if on the opposite side of the door, we open a window? That's, in that case, we will have the air, for instance, flowing in from the door and moving out from the windows. And this increases significantly the amount of fresh air that is coming inside. So, and that's why whenever it's possible, we should aim to implement this double-side ventilation, because this enables a higher volume of fresh air to fly inside. Hope it's clear.
Thank you so much for that. And our next question is directed to Prof. Okunsula. Is there a guideline or a manual that shows the recommended ventilation and space arrangements in low-income settings? Who checks the specifications are met locally? Is this part of IPC or not? Over to you, Prof.
I think there are a number of questions there. First of all, is there a guideline? WHO tends to give us general guidelines, because when they make their guidelines, they also take into consideration low and medium income countries. So there are some guidelines. I don't know the specific ones you want, but in terms of ventilation, yes, there are guidelines. And I think Luca gave those to us. Are there specific ones in every local area? I think a lot depends on your countries. I know that some countries have some manuals, but many of our countries really don't. I think South Africa has some manuals on, there's a society, I think Anna can help me here, Safi, I can't remember that are biomedical engineers that have, that work on hospital environment. So there are guidelines around the world. And I think there's some in South Africa, there might be some among some biomedical engineers, but these are some of the things that we need to start talking together and working together. So I think there are, whether they're always available, that you can find them, that's another matter. But I think WHO is a good starting point for most of these guidelines. And they have some extensive ones on the environment, on I think even the manual from, I think the one from, 2009, 11, has quite a lot of examples from other low and medium income countries like Peru and so on, that you can have open windows, different types of designs that you can use. So there are some things to use. I can't remember what the last question was.
The last question was, is this an IPC issue or not?
It is an IPC issue. It's about the built environment. More and more we recognize that the environment and the space can make IPC, can facilitate transmission or reduce it. So things like how the air flows, like the airflow that we've talked about today, what kind of windows and where are they placed? Have we got the rooms to isolate? Do we have good water? How does the faucet go into the tap? Is the tap deep enough to reduce aerosol? So the issue of the environment, and we're now talking a lot more about the flora within the hospitals, because really you should consider one of the most dangerous places to be in is probably a hospital, where a lot of people with infectious diseases and vulnerable people are put together in the same space. I mean, that whole scenario facilitates transmission of infections. So the way the hospitals, the wards are built is an IPC issue. And if you think about the core components, where we have the core component, I think core component 8, where it's talking about the built environment, the kind of finishes that you use and so on, and talks also about wash and water, then you start to appreciate that it is foundational, and it's actually foundational to IPC. How do you do IPC where you don't have good water? How do you do good IPC when the surfaces are such that they trap organisms? And even when you're cleaning, your disinfectants cannot reach the organism. They can find creaks and little pots and little things to hide in. So yes, it is a major IPC issue, and it's an issue that we all have to start facing. And we need to advocate for that. IPC is considered when our hospitals are built, and it doesn't have to be expensive. As Lucas said, big windows. I mean, we may not have the money or the power to have these negative pressure rooms, and they're not necessary, absolutely necessary. Have big windows. If you have infectious diseases that they are moved, they are in places far away from, further away from places. When we're building our buildings, We've sort of built them to maximize where the wind flows through and things like that. So in a nutshell, yes, it is an IPC issue. Secondly, it doesn't have to be an expensive venture, but it means we have to be intentional. We need to understand the issues, and as much as possible, as we're moving forward, not make the mistakes of the past and start really, planning with our engineers and so on, how to make our hospitals more infection unfriendly. Thank you.
Thank you so much, Prof. Ogunsula, for that. And additionally, participants, if you can check also on the chat box, Dr. Luca has posted a link for the guidelines on natural ventilation for infection control in healthcare settings. Kindly click on that link and you can have access to the book. Thank you. And then the next question is to Dr. Fontana. Where do healthcare workers and community residents go for advice on adjustment in the built environment? Beyond COVID-19, respirable agents are several, and several healthcare facilities and homes are poorly ventilated. Do you have any recommendations? That's part one of the question. And then secondly, what are the cost implications of these adjustments? And this will be the first considerations of the decision makers. Over to you, Dr. Fontana.
Thank you. And I put on the video just for this question because I want to back up what Prof. Ogunsula just said. It's our problem to make sure that our healthcare setting are IPC compliant. But we cannot do that alone. We need to work with the Minister of Infrastructure, with the Architecture Association of our country, with the Engineer Federation of our own country. Because what we have today, beside this 6 or 12 air change per hour and the 60 and 160 liter per second per person recommended for isolation, airborne isolation room, we don't have other standard. We don't have other standard. So we really need to sit with our technical building environment colleagues to develop this new standard. I understand the cost discussion. I completely understand this, and that's why I close my presentation with an example of long-term approach for a structural design facility, primary healthcare facility, suitable for TB, suitable for COVID and other respiratory pathogen. I agree, COVID is not the only one, TB is not the only one. So it's extremely important, and that's why it's extremely important for us as IPC community to lead this exercise in the future. We start understanding the mechanism of airborne transmission. That's for me the truth. We start now understanding, we just scratched the surface. And it's important to work side by side with our building and environment colleagues, architect, engineer, and the regulatory body that issue this guideline for the future. We need to change the way we look at the technical component of IPC. And Prof. Ogunsula mentioned before, water, sanitation, finishing and material, and ventilation. This is something we have to take ahead and push forward for the future. There is no magic bullet today. What we can do is improve the current situation with the solution we have available, opening the window, installing extraction fans that are not extremely expensive at the window on the wall, but in the meantime, please working with our technical colleagues to make sure that ventilation in healthcare setting became a standard, and not only in healthcare setting because we spend the big part of our day, our life in indoor space. So it's important to look with an holistic perspective and make sure that ventilation and IPC stay connected. I hope it helps.
Thank you so much for that, Dr. Fontana. The second question directed to you, it reads, what's your comment on the use of rovers instead of ordinary ventilators for ventilation?
Thank you. I saw this question before, and it doesn't really make a big difference because both the regular fan and the rovers, they just recirculate indoor air. So they're not bringing in fresh air from outdoor, and they're not filtering the air. They just mix and push the air. On one side, they're good because they ensure that our air is well mixed, which is a positive point. On the other side, as I mentioned before using fan air conditioning in healthcare setting, please make sure that the ventilation rate requirement are met, because we don't want to recirculate dirty air. Over.
Thank you so much for that. The next question is directed to Prof. Okunsula, and it's about the mechanical ventilation using an AC. The question reads, in my previous company, we were using AC in a closed conference room where there was no window, where there is no window and door. Even the door was closed, and we sat in the conference room wearing masks, door closed and AC open. Do you think this is protective?
Absolutely not. I think that's very clear. Let me say, first of all, if somebody, you were all wearing masks, and I think this really speaks to how, when we talk of protection, it's a series of controls, with PPE being the last. And what you're demonstrating there is we just took PPE alone out of all the things required to protect us against a respiratory virus. So essentially what is happening is you're sitting in a sea of organisms, sort of, and hoping the mask will protect, and the mask is not sealed. So you're going to breathe in, and the air is going to go in through the sides of your mask. So you are not protected. So I think one of the most critical things in a respiratory tract infection is the first thing we talk about is let's eliminate it. Let's get rid of it. If we can, how can we make sure that you have less organisms around? By ventilation. So you've got to open windows. Now, I understand, especially in our part of the world, I live in Lagos and it's extremely humid. If you don't have the air conditioner, you're going to be sweating. So we leave a little bit of the window, we open the window so at least some air goes out, and you open the windows in different places so that you don't totally close up the room. So we never close up the whole room so that the air still goes out and it's replaced by some fresh air from the outside. Is it ideal? No, it isn't. But it is still much better than having everything closed up. So what happens, and I think Luca showed it so well, if you sit in a room, because the air conditioner just circulates the air you've got in the room. If somebody has a COVID, for example, and as he's breathing, some of it is going to get into the air. It's just going to get more and more concentrated as it moves. And then the way the air conditioner moves, and it's been shown in some of the outbreaks, there's turbulence, and some people get quite a bit of it depending on how the air is moving. So you end up, even with masks, if you sit there long enough, you're going to end up getting the infection. So to keep it very short, PPE alone, without the other controls, is not good enough. PPE in a dangerous situation, which is that you are in a closed room, ventilation, no exchange of, no added air. So everything you're breathing in is just getting more and more concentrated, it's being circulated around. And over time, you build up the aerosols and the, in the air, it just gets more concentrated. So as much as possible, please have windows open, or sometimes it's said, open it at different times to, get rid of the air within that space. I know it will be impractical to say don't use air conditioners, but at least we can use air conditioners and have some of our windows open so that air does still come into that room and it's not a closed space. And some of the at least I can speak from Nigeria, some of our worst experiences during the waves have occurred from situations like this. People having meetings, people in these big marquees, having a party, and the marquees are relatively closed and they've got air conditioners there and they have a lot of people there. A lot of people have died secondary to that. So those are situations that you want to avoid. One of the most important things for airborne infections is ventilation, ventilation, ventilation. You need to dilute the concentration of aerosols. So that's not, so thank you. I hope that helps.
Thank you so much, Prof. Okinsula. It was very detailed. And the next question, I would direct it to Dr. Fontana. It says, listening to this presentation was very insightful, but I worry because here in the Seychelles, there's very tropical weather. Most of the facilities have installed residential AC in the wards, in the COVID-19 testing station, in the isolation rooms. What do you suggest is the way forward from now on? Over to you, Dr. Luca.
Thanks a lot. And I think Professor Monsula already answered this question, which is, I understand it's very hot and humid. So we completely understand the fact that air conditioning helps for patients and staff comfort, but leaving the windows slightly open throughout the day, it might have an impact on the overall temperature. So maybe we're not going to have 20 degrees inside, but we're going to have 22. But we at least reduce the risk of infection inside. One problem of that is that for sure there is a carbon cost and an environmental impact as well. So that's why it's important when we design a new building as well to keep this in mind. Maybe rather than installing a residential air conditioning system working with air recirculation, to consider the installation of an air conditioning that is ducted, which means that take air from outside and replace the old air from inside with the new, fresh and cold air from outside. For sure, this is something that should be done before, at the beginning, so before installing an air conditioning. But in the meantime, as solution, just make sure that you change your air regularly, either by leaving the door slightly open during the time or by opening your door and your window few minutes every hour. Thank you.
Thank you so much for that. Our next question is on ventilation in the emergency medical services. And the question would read, would you also opt for natural ventilation when you are in emergency medical services? Over to you.
Sorry, it's for me, right, Liz?
Yes, it's for you, Dr.
Okay.
Luca.
Thanks. But this is a nice question. And actually, as I mentioned before as well, I mean, everything it's on a case by case. So how long the patient is going to stay in the ambulance? If it's a short itinerary, for sure the staff is wearing a PPE, so it might not be a problem. But if it's a long transfer, yes, that in that case, we should either make sure that there is a mechanical ventilation system, which it's the case for many of the modern ambulance, And if it's not the case, make sure to leave the window slightly open to ensure that there is air circulation to dilute the potential airborne aerosol inside the ambulance. For sure, it's not the best option, okay? But if the ambulance is not equipped with a mechanical ventilation system and a division, a separation in between the driver and the patients, yes, please leave the window slightly open, because that's help. And for sure, especially consider that the medical staff will be in very close proximity with the patients. Make sure that they wear the specific PPE, mask, goggle, and so on. Hope it's clear.
Thank you so much for that. Our next question, I would like to kindly ask one of the interpreters, whether it's Ali or Ali, if they could read the question so that some of our participants can also get to understand the question from Ramatu. Ali or Ali, please help translate in English so that the question can be answered. Thank you.
Hello, Lizzie.
Yes, please go ahead and ask.
I am speaking from a different device, so you can hear me. This question is in French. It's not in either Portuguese or Arabic. Yes.
Oh, okay. All right.
I can help.
Yeah. Okay, if you can help Luca, it's better.
Yeah.
Yes.
So actually what it's saying is that during a discussion group, university, school, webinar, there are many discussion points on COVID-19 vaccination and fertility. And this kind of the similar webinar, similar workshop like the one we are carrying out now will be useful to respond to people concerned, and especially for general public, because it will be a way to reassure people about the safety of vaccination. So it's more an advice for, I guess, ICAN Africa CDC to organize a similar webinar on COVID-19 vaccination.
Thank you very much, Dr. Luca, for the translation. And I think Africa CDC and also ICAN have taken note of that and will be able to address that in the next series or the next coming webinars. And the last question on the Q&A box is about the AC systems. And I would like to direct it to you, Dr. Luca. Extraction AC systems any better? How can someone check the difference between traditional AC, which is recirculating system, and the extraction AC systems? Over to you, Dr. Luca.
Thank you. I mean, given that I'm not a specialist in air conditioning nor an engineer, I would say that so first, the best way is just to ask to technical expert, but in a very simple way is ducted. So air conditioning that are ducted, so that are connected to the outside, and they takes outdoor air, they cool it down and they bring it inside the space, are better for our specific context than air conditioning that just recirculate the indoor air. How to recognize the difference? I mean, again, given I'm not an expert, is that the air conditioning that are ducted, they are connected with the outdoor side, the outside, to take fresh air from outdoor, while the one that work only with the recirculation, they don't bring out outdoor air inside, so they don't have this piping connection. I'm sorry if I could not be more precise, but really that's not my specialty. Over.
Thank you and understood. Prof. Alkinsula, colleagues from Africa CDC, does anyone have an addition to what Dr. Luca had said?
Can you, well, I'm not an expert either. Could you, sorry, I missed the question. Hello? Hello?
Yes, Prof. Hello, Prof.
I missed the question, so I didn't really, but if Luca says he's not an expert, I can assure you I'm less of an expert in that area. So,
All right.
so I think that, thank you. But I did hear the question.
Thank you.
Thank you.
Okay, the question was on the AC systems, and it read, are extraction AC systems any better? And how can someone check the difference between the traditional AC, that is recirculating system, and the extraction AC systems? That was the question.
Okay, I think my answer will be less is worse than is going to be less in the sense that certainly I'm not an expert, so I really wouldn't know how you would know the difference. And I think that should be to an engineer. Just using logic, the extraction seems to be better. I mean, it just by the words, it is better, but I really wouldn't know how you would tell the difference. Sorry.
Thank you so much, Prof.
Lizzie, if you allow me to say something.
Oh, yes, go ahead, Dr. Ario.
Yeah, most of the, thank you so much, Prof. Most of these ACs, they come with manuals. And if you look at those manuals, some of them, they explain how the air how the AC is being operated. And some of them, you can actually change from recirculating air into exchanging air from outside. But the old ones, I don't think they have that system. And that is those ones that everyone is advocating, that if our healthcare facilities is having those old ones, I mean, the old ACs that might not have the settings to change from recirculating air to exchanging air from outside. So it might be difficult to control the transmission within the room. And in a situation where you don't have any source of natural ventilation within the room, maybe it's a meeting room or it's a conference room. Number one, as just anybody, whether healthcare worker or you are just participating as someone from outside, you need to use your mask because you are not sure. Number one, the AC that is being used within that conference room, you don't know the type of filter they are using, because the filtering system depends on the airflow rate. And if the filter they are using for their AC is not in line with the recommendation or the standard for the airflow of the AC, instead of the AC to be filtering the pathogens, so the pathogens might be going through those filters and also come back to the room if the filtering system is not appropriate for the airflow rate within that particular room. So it requires a lot of equipment to check all these things. And the people that are doing this, they have this equipment, they have these tools to check, but some hotels might not, or some conference centers might see this as a bit expensive to check or to assess before they give the conference room out. And sometimes there is an emergency of having meetings and there is no time to check this to make sure that the room is saved for people to attend the conference. So these are the things that I would like to advise, that if you are not sure of the filter or the filtering system for the AC that is being used within the room where you are attending the meeting, you better use your mask and use it appropriately. When I say appropriately, means it seal your nose and your mouth, and is helping you to filter the air you are taking in. And for the period of time that you are there, you make sure that you keep yourself safe. That is my comment. Over.
Thank you so much, Dr. Ario. And also, additionally, as Dr. Valerie has put on the chat box there, is that this is a teamwork effort whereby if you're not sure as what the panelists were saying, you can seek for further advice from the EHP and the OHS. At this point in time, I would like to thank Dr. Luca and Prof. Okinsula, and also thank Dr. Ario. The question and answer segment has really been very, very informative. And I would like to hand over to Anna for the closing remarks. Thank you, and over.
Thank you very much, Lizzie. And yes, I also like to thank our speakers, Luca Fontana and also Bethlehem from Africa CDC. Also our panelists, Prof. Okinsula, that really makes a big effort to be here on this call for us, Dr. Ario and all the other panelists, Briette and Lizzie as well, and also our interpreters. Thank you very much for the great work that you've done. I just want to reiterate that we will have 1 week break because this is the end of series 11, and then we will start with series 12. And we also are planning to continue with this until hopefully until the end of the year. So please watch this space. We will put it on the Telegram and also on all the WhatsApp groups and all the marketing material that we do have to let you know when we'll start again. Remember about the French session every week as well, and that will also continue. If there's anything that you would like to know or any possible topics on IPC, not just on COVID, but on IPC in general, overall, please send it to us so that we can also incorporate that into our discussion weeks, that we want to make sure that we do address your concerns. So thank you very much to everybody, and have a good afternoon or a good morning or a good evening. Thank you and goodbye.
Thank you and bye.
Bye-bye. Thank you very much.